Welcome everybody to this webinar today. We're going to cover 5 main key objectives during today's presentations. I'm going to cover the top 3 and Billy's going to cover the last 2. Primarily, we're going to talk about recognizing key radiological and nuclear threats, identifying key partnerships for collaboration, communication, and information exchange, identifying critical roles for public health in a radiological nuclear response, and Bill will talk about the development of incident management system structures appropriate to the different jurisdictions and development of plans, training, and exercises for rad-nuc emergencies. Just to give you an idea, I have the organization chart for my branch, the Radiation Studies branch. We're part of the National Center for Environmental Health. And as you can see, we're a very small branch. The technical staff, the health physics staff, we're primarily in the middle. So it's not a lot of us, but we do a lot. We develop a lot of products and tools so we can better assist everybody fully knowingly because there's not a lot of us to be able to go in person and assist. Why are we here? Well, because during a radiation emergency, state and local authorities will really need to be able to quickly assess the degree of hazard and issue appropriate protective actions for people in the affected area. And that's you, all of us. I want to cover a little bit on the terminology. Just as background, I will tell you that we recently developed a briefing book for public health officials. The idea behind that was to put something together that somebody totally unaware of radiation issues could read in about 2 hours as they're deploying to assist in a radiological emergency. And out of that briefing book, which is out for comments right now and hopefully will be published soon, I extracted some of the key concepts, and that's what I want to talk to you about today. I'm assuming many of you are familiar with the term CBRN, chemical, biological, radiological, and nuclear. Why do we have radiological and nuclear if they both involve radiation? Well, because they're different. They both involve radiation, but a radiological incident does not involve a nuclear detonation, whereas a nuclear incident involves a nuclear detonation. And I'll talk a little more about that in a minute. But the thing they have in common is that both of them can happen in unforeseen locations and will apply to all states and jurisdictions. And there's a variety of radiation events, from transportation to nuclear power plants to industrial to laboratory. It could be from a truck carrying radioactive materials for a hospital for a radiation treatment, to a lab in an academic setting, to terrorism and everything in between. So radiological events are not new to us. There's a different threat right now, but we've been dealing with radiological events for a long time. Key concepts, radiological dispersal device. It's a device that disperses radioactive material using conventional explosives. That's called a dirty bomb. But it could be dispersed by other mechanical means, such as a spray from a plane dispersing over crops. It could be contamination in the water. This poses a contamination and an exposure hazard. A nuclear emergency, on the other hand, involves explosion of a nuclear weapon or improvised nuclear device. And you can think of Hiroshima and Nagasaki. Those were nuclear emergencies. In that case, the explosion produces an intense pulse of heat, light, air pressure, and radiation. And they also produce fallout. And fallout is radioactive materials that can be carried long distances by the wind. As key decision makers, public health decision makers, there's a lot of information we're going to need. A distinction in the types of information we'll need if it's a nuclear versus a radiological incident. I pointed out in this slide. For example, for a nuclear incident, we want to know the type of device. Is it an improvised nuclear device? Is it a state-sponsored device? How big is it? Because the size of the device will determine the damage and the consequences. Which way is the plume going? And again, local weather is not that relevant because during a nuclear explosion, the material may go up a couple miles up in the air. So the weather conditions up in the higher altitudes are going to determine which way it's going to move. And the radioactive decay. Some of these radioisotopes will decay very quickly, and some will be there for long term. During a radiological incident, we want to know, is it a RDD or nuclear radiological dispersal device? Is it transportation? Is it radiological exposure device? Also, the acronym is RED, nuclear power plant, etc. What kind of radionuclides are involved? What's the half-life? Is it solid, liquid, gas? And do we have medical countermeasures available for that radionuclide? There's other pieces of information that are also going to be critical. For example, the impacted area. How far is the contamination? What are the radiation levels? What's the status of the critical infrastructures and services? I mean, some of these are common to any major disaster, not just a radiological disaster. Of course, with radiation, it becomes a little bit more complicated. We want to know the impacted population. How many people live and work there? You might be in a city that has a lot of transient population. People come in the morning, go home at night. So if something happens in the morning, the number of people impacted is going to be very different from people at night. Are there any special events? Is there a big football game, a NASCAR, some other place that you might have a large population gather there? What are the primary radiation hazards? Is it an exposure, a contamination, or both? Are there other hazards? Are there fires, collapsed buildings, secondary devices? I mean, with an improvised nuclear device, a lot of the damage is going to be from the pressure and fires and explosions, and there's going to be a big, big fat mess. And also, we need to know the response assets that we need to address the hazards. Do we have a search and rescue team? Is there fire, hazmat, medical, or are we relying just in volunteer services? They also need to be aware of safety precaution considerations for the first responders, the first receivers, and other emergency workers. It's not just going to be fire, police, EMS that are going to be responding. We're going to have other emergency workers, such as people in public works, moving debris so the emergency vehicles can go, bus drivers helping with the evacuation, staff at community reception centers, shelters, etc. They need to know the communications that are available. What kind of channels do we have? And the technical experts. And it's not just the subject matter experts of SMEs, but also communication experts, because we're going to try to convey a most likely complex message, and we need to be able to craft it in a way that the public can understand it. Which agencies do we need to contact? And that will be for notification as well as for assistance. Now, I don't need to emphasize that the better information we have, the better our decision making is going to be. Why? Because how much information we have will determine the most appropriate initial protective action, and that's where we can save the most lives. Now, for accidents that evolve slowly, such as a nuclear power plant, when we might have hours or days to take protective actions, it may be possible to evacuate people from an area before the contamination gets there, and actually that's the preferred protective action during a nuclear power plant event, is to evacuate before there's a release. But sometimes evacuation may present other hazards. We may be in the middle of a snowstorm or an ice storm, or bridges may be unavailable, or it could be other hazards that may put people at higher risk than the potential exposure. So it's important that decision makers take into account the risk of evacuation before issuing an evacuation order. Now, when we're talking about incidents that develop quickly, such as a no-notice terrorist act, the best course of action is to shelter in place. And shelter in place means go inside, stay tuned. I mean, shelter in place may mean different things to different people, but our message is to go inside, stay inside, and listen to the news to find out what you need to do. And give the radiation experts some time to assess the hazard and provide further instructions. Now, a radiological dispersal device, a dirty bomb, is unlikely to distribute a lot of contamination to present a serious exposure hazard. However, leaving a safe structure would put people at risk for internal and external contamination. Now, shelter in place is also the recommended protective action after an IND, because the radioactive fallout presents a real serious exposure hazard, and going outside will expose people to potentially very high levels of radiation. Staying inside a sturdy building provides shielding and reduces exposure. And the sturdier the building, the better. You can think of it as a tornado. A wooden house will not be as safe as a brick building or as another large structure or a basement. Staying inside, like I said, will provide shielding and reduce exposure. The other thing to consider is that radioactive fallout loses the energy quickly and becomes less dangerous as time passes. And I'll quote, there's a rule of thumb that we use in health physics, the 7-10 rule of thumb, that every 7 hours, your radiation levels drop by a factor of 10. So just staying inside 24 hours will reduce that by at least 3 or more orders of magnitude. So if we can get people to stay inside for 24 hours, we will save a lot of people that way. Now I'm going to talk a little bit about some of the roles and responsibilities, but Bill really will go into more details on the planning documents. But the response by the federal agencies is outlined in the RADNUC Incident Annex, and it has a very long name which you can read. I'm just going to call it the RADNUC Incident Annex. And the annex defines the roles and responsibilities, discusses the different authorities, capabilities, and assets that the federal government can bring to bear to an emergency. And it also discusses how the assets will organize and operate in conjunction with each other and with local and state response partners, because everybody will be involved, from the local to the state to the federal government. We're all going to be involved, and hopefully we'll all be playing nice together. Now, there are, in the RADNUC Incident Annex, there's a lot of responsibilities listed, but the ones that fall specifically to public health are the ones that I have bulleted here. 1 is conducting population monitoring. 2 is initiating health surveillance and epidemiology investigations, not just for the workers, but also for the public. The 3rd one is coordinating distribution of medical resources and countermeasures. And the last one is communicating guidance regarding use of altered standards of care and managing scarce resources. As you can imagine, if we have tons of victims, we might have to make some adjustments to how we do medical care, to how we distribute some of the medical countermeasures. Now, I mentioned population monitoring being one of the responsibilities of public health. It's going to be likely the most challenging responsibility for state and local public health. It is specifically stated in the annex that that's a responsibility of state and local health. We at CDC, we will provide technical assistance. We have a lot of tools to help you plan for that, but state and locals are responsible for that. And population monitoring begins soon after the radiation incident is reported and continues until all potentially affected people have been monitored and evaluated for a lot of things. Do they need medical treatment? Do they have contamination on their body or on their clothing? Do they have internal contamination? That means material inside their body. Do we need to decontaminate them? Did they receive a large dose, and will they pose a high risk for them? And also evaluate long-term health effects. Now, out of all those items, except for the evaluation of long-term health effects, all of them should be accomplished as soon as possible following the incident. It's likely that you will not do population monitoring within the first 12 hours, but hopefully within the first 24, 48 hours, you'll be able to set up population monitoring stations. Now, health officials will need to establish a population registry and conduct epidemiologic investigations to evaluate people for long-term health effects. And this process may span multiple decades. And we're still following people from Hiroshima and Nagasaki 60 years later. So we recognize that where health agencies may initiate this at the state and federal, state and local level, federal assets will come to assist with that effort. And this slide shows some special considerations if we're dealing with an improvised nuclear device. The one I want to highlight is we really want to prevent acute radiation health effects. So contamination in this case will be secondary to taking care of identifying people that need immediate care. The phases of radiation emergency, we classified in 3 phases, the early, intermediate, and late. Bottom line is in the early phase, we're dealing with life safety issues. And a lot of what we're going to do is going to be based on limited information, primarily from modeling. It's going to be confirmed later on as we get data, but it's going to be very preliminary early on. The intermediate phase, we're dealing with protecting people from chronic exposure, and that will involve the ingestion pathway, protecting, long-term effects like developing cancer. Late phase involves activities designed to return the affected area to normalcy or new normal. Just a couple quick slides on the federal assets. The Department of Energy has many assets. I talked about modeling. The National Atmospheric Release Advisory Center produced maps, early maps, that can help us determine which way we need to move people. There's a radiological assistance program. The aerial measuring system is an airplane equipped with radiation detection equipment that would allow us to do very quick detection in large areas. The FERMAC will bring together multiple agencies, and the Radiation Emergency Assistance Center training site, REACTS, provides medical advice. Now, there are many federal agencies that will have a role. I'm just highlighting a couple. The EPA has the RadNet network that was very, very important during the response to Fukushima, because they have currently 130 monitoring stations throughout the country, and they monitor radiation levels, background, all the time. So that will give an indication if there are any anomalies. And they do air, precipitation, drinking water. They also have a plane that can fly large areas, and they have the radiological emergency response team. And the last asset I want to highlight is the Advisory Team for Environment, Food, and Health, also called the Advisory Team. The primary representatives are from EPA, Department of Agriculture, Food and Drug Administration, and us at CDC. But it could have other agencies as needed, depending on the event. And the main point of the A-Team, Advisory Team, is to interpret the information and help state and locals make decisions, make protective action recommendations. So we're there to assess, not to make decisions. I mentioned Community Reception Center, population monitoring. It's a big deal. It's going to fall on public health. We have a lot of tools. I invite you to visit the CDC website. We have a lot of tools. We have specifically a Community Reception Center drill toolkit that has everything to set up a HCEP compliant exercise. And Bill will talk about HCEP also. I know that many of you work in laboratories. I wanted to highlight a couple things. Measuring internal contamination is going to be important, especially if we're dealing with a dirty bomb. Our lab has a urine bioassay method that was developed to quickly identify and quantify specific radionuclides. And also, that information will help us provide effective medical management. It's also going to be very helpful to provide negative results, because people want to know that they're not internally contaminated. Now, certainly, that can take a toll on all the laboratories. The good news with our method is that unlike most traditional bioassay methods, we don't need a 24-hour urine sample, but just 10 ml. So you laboratorians must be happy to hear we don't need to wait and collect that large sample. We have some rapid screening methods for gamma as well as alpha and beta emitters. We can do 25 plus priority threat radionuclides. It's CLIA compliant. Unfortunately, the throughput is only 300 to 500 samples per day. And if anybody's interested, we can put you in touch with Dr. Robert Jones, who runs the laboratory. Just a couple of slides on medical management. Why do we want to do urine bioassay? Well, because we have, for some radionuclides, we have some countermeasures that we can use. And this slide shows, for example, for iodine, we have potassium iodine, we have Prussian blue and DTPA, and we have colony stimulating factors. And the drugs work on very specific radionuclides. Not all of them will be useful, so it's very important that we know what we're dealing with. In an improvised nuclear device event, most likely we will only use the colony stimulating factors, because we will have a multitude of radionuclides. And just the last one or two slides, acute radiation syndrome may happen if people are impacted by an improvised nuclear device. It's also called ARS. And that illness develops when a person receives a high dose of radiation over a short period of time. So it would only happen if radiation dose was high, if it can reach internal organs. So we're talking gamma radiation. Most of the body is irradiated, and it was done in a very short time. And the symptoms include nausea, vomiting, headache, diarrhea. And the symptoms and severity will depend on the dose. And there's some treatment, again, depending on the symptoms, what will be done for treatment. And that's a listing of what we currently have on the Strategic National Stockpile. And just want to give you a sample, some of the questions that we deal with in my team and the radiation team during an event. We help develop and review content for products used by the Joint Information Center. We work with the advisory team. We provide input on medical countermeasures, worker safety and health, etc. And I'm just not going to read them, but those are some of the questions that we handle during the exercise that Bill is going to talk about, the Gotham Shield. And not only which ones are important, but we need to answer why some things that we have in our guidance will not apply to this emergency. And with that, I'm going to turn it over to Bill to tell you why we told you all this. Thank you very much.
Thanks, Adela. And thanks, Adela, for setting the table for this. And right now on your screen, you see, so how does the CDC effectively prepare for these types of events, for a nuclear radiological threat, such as an improvised nuclear device? So we actually have a model that we follow. There's a preparedness cycle for doing plans, training, exercise, and evaluation. And the schematic here shows the preparedness cycle. It is a cyclic. It does start at any point, but we usually start in the upper right-hand corner with the plans, whether that's need to be created or there is we're revising a plan going forward. Obviously, looking at equipping, organizing, training, exercise, and evaluating and improving, and then going back through the cycle again to increase our preparedness activities and our readiness. So we begin with the plan. So just to kind of lay the foundation, emergency management plans, looking to as simple as possible, but they may get complex as necessary based on the type of threat we may be dealing with. So looking for well-written plans that are timely and effective. They're implementable by the response activities and those folks that are in the response. We take an all hazards approach and then we go off of that. So I'll describe how CDC does that on the next slide. But we have branches that come off of that based on the threat. Just having a plan does not guarantee that your readiness and your preparedness goes up. So having a plan, but to exercise it is the next step, that's what we're looking to do and to increase here at CDC as it relates to a nuke rad event. So here at CDC we have an overarching all hazards plan, and off of that we have supporting incident-specific annexes, appendices, and other attachments. We run the gamut from, there are a number of branch plans to this. We have biological, number of plans within biological, chemical, other natural disasters such as hurricanes, earthquakes. We also have, again, focused here on nuclear radiological, and we have those plans in place, and we are in the process of updating. So let me talk a little bit about the nuke rad annex. We have two documents as of right now. We have one from 2010, which is our nuclear radiological annex, which when it was developed. Since that time, in 2015, we actually developed a task matrix. This actually specified more of the roles and responsibilities across the agency as we were going forward. And then in the lower right-hand corner, you'll see, as Adela talked about, the Nuclear Radiological Incident Annex, which is part of the Federal Interagency Operational Plan. That's a parallel plan that actually got published in 2016, so we use a lot of that information as well in forming our plan and our revision, which started in 2016, and we've been utilizing the draft ever since. So as you can see in the upper right-hand corner, we are in the plan phase, getting ready to move into the organization and equipping. So where does this response staff come from? This is the acronym slide, and as I don't have time to explain all of these acronyms, they are all organizations here within the Centers for Disease Control and Prevention. And how we organize and equip these folks into the plan, these are all organizations that do have an identified primary or supporting role to our nuclear radiological annex, and specifically to an improvised nuclear device. So we utilize at CDC, we utilize the incident management system as most elements in the government use. We have to organize that and have those folks that come on board, where do they go, what do they do, what skill sets do they have. We provide a structure, we utilize that structure which is flexible, scalable to the type of event. And as we look at this, we're looking at the first 48, 72 hours. So instead of trying to take a bite of everything from beginning with the response from detonation all the way to recovery, we focused on the first 48, 72 hours to maintain our focus. When we began this with this structure, it was a blank screen. There are a number of pieces and parts to our IMS structure. This is the command staff. This is what we have as of right now. based on our year of execution of these exercises and planning. This is where we're at right now. This is something that is a living, breathing document as we move forward. And again, this is directed by, if we do activate here at the CDC for an IND response, this is the structure we would begin with in the first 48, 72 hours. So as a part of that, unique to CDC, we have a scientific response staff utilizing our expertise across the agency to come be a part of this response and fill out this response staff. Again, we're focused on the first 48, 72 hours. There are a number of grayed out boxes here across the epidemiology and laboratory task force, medical care and countermeasures, worker safety and health, non-medical countermeasures, and environmental health. A lot of those things that are grayed out are those elements that we anticipate being a part of this response once we get into the 72-hour and beyond mark. And then our coordinating staff, we have a number of folks that are continuously supporting these types of responses. We have our general staff, we have these specific specialized elements that support our incident manager and also the CDC as a whole. So why do we conduct exercises? We want to try to practice these problems and these emergencies before they actually occur. If we're able to get better at doing so, we'll be better prepared in case the real thing happens. So this is across, as you look at the preparedness cycle, we're kind of bridging across. We're still organizing and equipping. We're still training. We're doing that individual training. And then with exercises, we're bringing the collective together to practice those things now so that we don't have to worry about trying to pick it up later on game day or when these actual events happen. So again, the methodology for exercise, again, looking at a baseline assessment of our organization's capabilities. We take a look at what CDC provides. As Adela covered, there's a lot of things in public health. There's a lot of those bullets that population monitoring, epidemiological investigations, et cetera. Those types of things, those are our capabilities, so we need to assess that. Then we got to prioritize. Again, by necking it down to the first 48, 72 hours, we're able to focus on those and able to give the incident manager at least a chance to understand how those priorities fit into CDC's capabilities. And then we have proven cases where we use exercise design, development, and evaluation. Again, the Homeland Security Exercise and Evaluation Program, HCEP, provides us that guideline, that provides a guideline for us to use, and then we can model how we need to go forward. Various types of exercise, just to kind of lay the groundwork. There are two types, discussion-based and operations-based. The schematic here to the right is kind of a building block approach. It's very progressive in nature, in which you see a number of the discussion-based exercises to the left with the operations-based exercise to the right, all escalating. And kind of naturally, as you progress to the right, the planning and the training that is required increases. But yet, as we increase that amount of coordination and the ability to reach the pinnacle, a full-scale exercise or much less a functional exercise, we are increasing our capabilities by putting those into practice. So again, discussion-based exercises, seminars, kind of setting the groundwork for and presentations and making sure everybody understands the same level of the information we have. Workshops to develop those products that we need going forward. That may be a plan, it may be starting from scratch, or there may be a policy or some other procedures that we need to develop. Tabletops, bring it together. Let's put that plan to the rigor in a discussion, in a room, in a conference room, so that we can talk through those things with our leaders about what things will work, what won't, and try to capture those things before we start expending resources. And speaking of expending resources, that's what we do when we're doing operations-based exercises, even beginning with drills. Drills can be something as simple as picking up the phone and making a phone call, and who that phone call goes to and what's being described. There's an SOP built in with that alone. We advance to those communications across a number of elements. It could be internal to our agency, CDC, or with our external partners in the state and local elements. Full scale, we are expending resources. We are interacting with everybody as those things happen, so there's very minimal simulation or replication of activities. So based on all that information, what we saw here at CDC in tackling the improvised nuclear device problem, for us to do a response here at CDC, we built the NUCRAD Training and Exercise Program, NUCRAD TEP, in FY17. We began last year about this time in October, and we utilize some existing things. We utilize a scenario which is built in a national planning scenario that is the #1 scenario there, and it is for an IND detonation in a large U.S. city. We identified a number of those types of exercise that we believe progressively would help our agency, help those folks that are in response to advance. And we've selected 3 tabletops over time, originally 2 drills. We set up a senior leader seminar as well as a major functional exercise which was all leading to that major event. It takes a lot to do this. It takes an exercise planning team. We had to assemble that exercise planning team based on all those response staff across this whole agency, that acronym slide. We needed a representative or 2 from each one of them to come join us. That added up to approximately 60 when it was all said and done, and there were others that came and went, but we had all those partners working with us on this planning team. We again utilize an HSEEP. We utilize the formal planning meetings over time, over this time frame, concept and objectives meeting, setting the beginning. An IPM is an initial planning meeting, mid-planning meeting is MPM, and a final planning meeting before the execution of the events. Got to keep the leadership involved, getting them briefed, getting them to have buy-in, and then providing updates as you move through the process and making sure you incorporate those into your planning. The means of communication. A lot of times we can't get a conference room or a room to meet. We leverage virtual technologies such as Zoom in order to have those things happen, because we may have folks in Cincinnati or over at another campus here in Atlanta. They can join us pretty much at a moment's notice with some of those conferences and some of those meetings. Getting the venues set up and equipment, rehearsals, execution, having a great facilitator for a number of your discussion-based exercises is key to that. And then having an evaluation plan. You got to have an evaluation team on this exercise planning team to make sure that you got all the bases covered, and we are training, we are learning, we're capturing those things that we do well, those things that we may not do too well. So I'm not going to read you this slide, but these were the overarching objectives for our training and exercise program for the year. Normally for each event, there's approximately 3 to 5 objectives that I would recommend that you would do, but all these touch some way, somehow on all the activities that we had going out throughout the year. And this is how it looks kind of over time and space. So subjectively, we want to increase our preparedness, increase our readiness here at CDC, and that's what the vertical structure on the left shows. We're just really in the nascent stages. We're really in the beginning here at CDC as we look at an IND threat. And while there's been a lot of work done over a number of years, this is one of the first times we're able to pull it together, and we had a lot of leadership buy-in, and that enabled us to progress, to move up this ladder, if you will, towards a walk, towards a run. And in 1 year time, I think and I'll talk about it a little bit later, but I think we made a great start in this first year. But this lays out the order in which we conducted those types of exercises. But all the while, you see the line below, there's still individual training going on. There's a number of schools, a number of classes and courses that are taken by the response staff that enable them to do their individual job and then do it collectively. So this lays out, there were a number of 11 events that we had over that time frame. These were the dates of them, and again, their focus on a number of different things. As I mentioned, you see IMS structure here throughout. That's a living, breathing document. We spent a lot of time developing that as we move forward, and that helped tremendously as we led into the major event on April 24th to 27th, the Gotham Shield 17 event. I'll talk a little bit more about here in a moment. But the total events there at the bottom, we did 3 workshops, 3 tabletops. We added a drill. As I mentioned, the plan at the beginning may not survive first contact. We identified, hey, we need to add a drill to this, and we did. Senior leader seminar and a functional exercise, Gotham Shield in April. So all those formal planning meetings, those 4 planning meetings are not going to cut it. With 60 folks on the exercise planning team and a number of other leaders to engage with, as well as external partners and state and locals, we had to come together as smaller groups, work groups, to accomplish this. Again, a lot of acronym here, but bottom line is 37 planning and training activities to execute these 11 events. Tremendous amount of work by a small number of folks. And just very quickly, again, kind of in order, began with a tabletop, kind of setting the stage, again, focusing on that early IMS structure that we were pulling together, talking about activation, just the bare bones. How do we activate? How do we get contacted? And who's being contacted? Who's actually staffing these positions? Those early days that we had last year, November. We went into a drill. We actually conducted a 4-hour drill. The interesting thing was we had real world issues. We had a power outage during this. So it actually raised the threshold on folks that were participating in our drill, but it also brought a lot of realism to the folks that this may actually occur in this type of event, an IND event. We went in tabletop, took all those things, all the feedback, all the information that was coming in from our leadership and those on the planning teams and across all of CDC, and started refining that structure some more, talking about the means of communication and how this response is actually going to work. Again, setting the stage for our senior leaders to come together, have the conversations about this type of threat for the agency, and capturing that information and incorporate it into our training and our exercises. And then the main event. The main event was the Gotham Shield 17 improvised nuclear device detonated in Region 2 involving New York City, New York State, New Jersey, among others, a lot of federal interagency, DOD, and to include us here at CDC. We were able to ride that backbone of this national planning scenario, number one, and everybody was able to utilize that as the basis for this. And so this was a great opportunity for our experts, for everybody that was on the response staff for an IND here at CDC, to actually put the things that they've learned over this time frame, just a short 6 months, to going into April and being prepared to tackle this type of response. So a lot of highlights and outcomes came out of this, again, informing to our revision of our annex, the refining our IMS structure. Does it actually work in practice? A lot of lessons learned from that. Revisiting, hey, the medical countermeasures, as Adela was talking about, we have a number of medical countermeasures, but do we have the right amounts? Are they the right type? Can we get them to the state and locals in a timely manner? Then the public health messaging, probably the critical piece, looking at those messages that are pre and post incident, you know, before boom and after boom. We're able to refine those through the use of this exercise. Tremendous opportunity for the communications folks with our scientists. And then we're able to leverage and test the equipment at one of our alternate sites, the Coop North site here in Atlanta. It doesn't end with the main event. It still continues. We need to capture those lessons learned. We still did some things wrong. We still had some shortfalls. We got a lot of gaps. Can they be solved with money, staffing, processes? What are those things? We had a tabletop to discuss that post Gotham Shield. And we started putting some of those things into practice. We did another drill. We did drill number 3 to put those things into practice, to capture those lessons learned a short time before, from April to July. Evaluation throughout the process. Every training event, every exercise was evaluated. Otherwise, it's just an event. And we have a lot, our evaluation teams are robust. They're varying. They take different methods of collecting information. They provide the hot washes when things are happening. Things just ended real time. Let's capture that information. Do a senior leader AAR to get their feedback immediately, and then provide a formal documentation in the form of an AAR within a few months. And then one of the main goals of this whole year was the refinement of our incident annex, which the last update was 2010 with a supplement in 2015. We're looking at publishing that here in 2017. At the top here you see we've gone full circle. We've come up to the evaluate and improve, and now we're going back to the plan. We're revising the plan so that we can go forward and do this process again as we move into FY18. So looking at that assessment and recommendations, again, good start. We have some subjective observations of this. We feel like we got a good start. We didn't think we were going to get in the crawl, walk, run much past the crawl phase. And you know what? We actually got pretty high on that level as far as we're concerned, as far as our preparedness and readiness. So we feel like, to use Adela's term, we feel like toddlers kind of hanging onto the furniture, ready to take that first step. Great feeling to have as you come out of that first year. So we feel like we got a higher level of preparedness based on our revised plan. We definitely have on board, everybody understood and got very comfortable with the Nuke Rad TEP program. So we're going to move into this FY18. We're We're going to try to get to the walk level. We're going to go in the FY19, try to get to the run level, and then maintain as we go into the future. And obviously, we've shared through the individual training and through this process, we've kind of coined the phrase nuke-rad savvy. As Adela showed on our very first slide, very small health physics organization here at CDC, and probably across your organizations and most organizations across this great country of ours, there are not a whole lot of health physicists out there that can help in these types of events. We feel like we've just shared a lot across the board from not only our scientists and doctors and nurses to everybody within the organization now feels like they have a better understanding of a nuke-rad event, an IND event. And with that, we've kind of reached the end of our presentation. Again, these were the 5 objectives, the 3 covered by Adele in the first half. And hopefully I've covered the last 2 bullets for you as our objectives. And I believe we are prepared to answer any questions that you may have.
So we have one question from Tara Cameron. If a nuclear event occurred, are the drugs like iodine available?
Well, for iodine, that's usually used during a nuclear power plant event, and that will be potassium iodine. The potassium iodine, the way it works, you need to take it before exposure. That means if you know that a release is coming, or no more than 4 to 8 hours after that. After that time, excuse me, it's no longer effective. So it's very limited. It only protects the thyroid, and it only protects it, for a very short time. For any other event, potassium iodine would not be effective. The question to ask if iodine was available, some states that have nuclear power plants have stockpiled potassium iodine, and some have pre-distributed, so it depends on where you are. Yeah. There may be some, and the best way to check is with your planning people.
Thank you. Thank you for following up with that. While we're waiting, do we have any other additional information you guys like to provide, or anything from our guest here?
So just from a exercise perspective, again, we focused on nuclear radiological and building out a training and exercise program, nuke-rad. We have a number of other areas that we also focus on, again, another public health scenarios. Again, we're looking at a pandemic influenza training and exercise program starting now, and will actually run for over 2 years in the first kind of iteration. Working with our counterparts at HHS and working towards that in the calendar year 2018, which is the 100-year anniversary of the Spanish flu. So we'll be focusing on that, as well as going into, we're very excited about our year 2 for nuke-rad TEP, and able to continue that and keep on propelling forward with our preparedness and readiness there.
And I want to say that we have a lot of tools on our website at cdc.gov. If you just type radiation, it's going to take you to both our emergency page or non-emergency page. In the emergency page, we have information for clinicians, for public health, and for the public. By topic, we have a very large library of publications and tools, toolkits that can be used to plan exercises for a shelter or for a community reception center. We have quite a few, and our contact information is there if you happen to need something specific.
Perfect. Thank you.